Hello, everybody. I am Dr. Raktim and I am here to discuss a topic of epidemiology of rabies. Coming to the introduction, rabies, as we all know, is known as hydrophobia. It is an acute, highly fatal disease. You can imagine the fatality of this disease is that till now, only 3 cases of rabies have survived till date, of which the most famous case, the Milwaukee case of 2004, where a 15-year-old girl was bitten by a wild bat and she survived. With this, some Milwaukee protocol was developed, but later on it was found that the fatality of the rabies is 100% and the protocol was not that effective. The rabies virus is caused by lysavirus type 1 and it affects the central nervous system. The mechanism by which rabies is caused is very interesting. When a rabid animal bite a certain host, from that wound, the rabies virus travels in the host. It travels in a retrograde manner from the nerve endings towards the central nervous system. While traveling, it escapes the body's immune mechanism and finally it reaches the central nervous system. Upon reaching the central nervous system, all the signs and symptoms occurs like encephalitis, convulsions. Then, at that point, if any medicines or antivirals are given, uh, it do not get sufficient time to work as it cannot identify the virus in the early stage. And since the virus has reached the brain, the blood-brain barrier also provides resistance for the medicines to enter the brain. And thus, due to this stealth nature, the rabies develops. It is primarily a zoonotic disease of the warm-blooded animals. So, it is the only communicable disease of man that is 100% fatal. But it is also 100% preventable if the prevention and treatment are given in timely manner. Coming to the geographical distribution of rabies, it is both enzootic and epizootic disease. When we say enzootic, that means it is endemic to the animals, and epizootic means when an epidemic of rabies occurs in animals. Thus, rabies can be found both as enzootic form and epizootic form. Some of the countries are rabies free, like the Australia, Cyprus, Iceland, Ireland, etc. Few of the places like Australia or New Zealand are rabies free because of their geographical isolation, and these are island countries. Similarly, in India, the islands of Lakshadweep and Andaman and Nicobar Islands are rabies free. When we say rabies free, I mean that when an area has no case of indigenously transmitted or acquired rabies in man or in animals for a period of 2 years, then we can declare that area to be rabies free. Moving forward to the agent factors of rabies. As discussed, rabies is caused by lysavirus type 1 and it is a bullet-shaped neurotropic RNA virus. It is excreted from the saliva of the affected animals. The source of infection to man is the saliva of the rabid animals. In dogs and cats, the virus is present in the saliva for 3 to 4 days. Coming to the host factors, all warm-blooded animals are susceptible to rabies. In man, it is a dead end infection. The vulnerable population who are at risk for acquiring rabies are number 1, age group of 1 to 24 years. The probable reason for the vulnerability to this age group is because since 1 year, 2 year, or small children often get bitten by rabid animals. mostly dogs in India. Then they often tend to neglect the wound and thus they are at higher risk of developing rabies. On top of that, the immunity in case of children is not fully developed. Similarly, the site of the bite is more closer to the face or the central nervous system and thus it leads to severity in this age group. Second group are the laboratory staff working with rabies virus and the veterinarians. You may wonder why this population is more prone to acquiring rabies. It is because the laboratory staff who is working with rabies virus in the laboratory, that person might get rabies through aerosols. The veterinarians, the dog handlers, hunters, and field naturalists are prone because of their occupation. They might get bitten by the animals, and sometimes, if they tend to overlook it, they may contract rabies. Thirdly, the hunters and field naturalists may get bitten by an wild animal, and according to the protocol, all wild animal bites are severe. Moving forward to the mode of transmission. As discussed, people gets infected by deep bite or scratch by an infected animal. In India, dogs are the main host. In some countries like USA and Canada, bats are responsible. Transmission occurs when saliva comes in direct contact with the human mucosa or fresh skin wounds, as it was discussed in the mechanism of rabies. Human to human transmission is theoretically possible, but it has not been documented in history till now. As I was saying, the rabies might get transmitted by inhalation of the virus by aerosols. Primarily, it is seen among the laboratory personnel who are working with the rabies virus in their labs. Moving forward, the transplantation of an organ may also cause rabies transmission. However, these are very rare causes, and the main cause that we have to remember is the bite of by an rabid animal. It is interesting to think that the ingestion of raw meat or the tissues of an infected animal is not a source of human infection. It is only transmitted by a bite by a rabid animal or rarely by aerosols. The incubation period is 1 to 3 months after exposure, but it can go up to years. The incubation period depends upon the site of the bite, the amount of virus present in the wound, the species of animals. Here I want to highlight that the wild animals bite are all severe, while the domestic animal bites are less severe compared to the wild. The protection offered by the clothing, the treatment undertaken. Here, when a bite is there over the skin, which is uncovered, then the uh, amount of rabies virus coming in contact with the skin or the wound is more. Comparatively, if the skin is covered by some clothing, then the amount of virus in the wound would be less. Treatment undertaken, I mean that if the treatment is sick in early stage, then the chance of survival is more. If the treatment gets delayed, then the chance of death becomes more. Coming to the clinical picture of rabies in men, it starts with the prodromal symptoms of headache, malaise, sore throat, and slight fever for 3 to 4 days. It is followed by the excitation and stimulation of nervous system. The intolerance to noise, bright light, or cold draught of air, which is known as aerophobia, is seen. For some researchers, They told that aerophobia is one of the pathognomonic signs of rabies. These symptoms progressively gets aggravated and the characteristic hydrophobia is seen. Hydrophobia is the definite pathognomonic sign of rabies in men. This stage lasts for 2 to 3 days, but it may get prolonged for 5 to 6 days. Due to the involvement of the central nervous system, the patients usually have episodes of convulsions, and such abrupt episode of convulsions may lead to paralysis, or that patient may be in the stage of coma or may even die. ICU may allow occasional patients to survive. Here I want to highlight that the Milwaukee case that I was saying, which happened in 2004, she was a 15-year-old girl who was bitten by the bat. She was put in induced coma, and later, after 1 or 2 weeks, she survived. That was the first documented survival of a clinically developed rabies case. Coming to the diagnosis, it is generally clinical, based on the history of bite by a rabid animal. Other techniques, such as immunofluorescence of the skin biopsy, are there, but it is of research interest and they do not provide any help in the clinical setup. How do we prevent human rabies? It is considered under the following. Number one, the post-exposure prophylaxis. Number two, the pre-exposure prophylaxis. And number three, the post-exposure prophylaxis for persons who have been vaccinated previously. Coming to the post-exposure prophylaxis, the aim of this is to neutralize the inoculated virus before it enters the nervous system. It is always treated as a human emergency. How do we start the PEP of rabies? Firstly, the local treatment of the wound. The main aim of the local treatment is to remove as much virus as possible from the inoculation site before it gets absorbed by the nerve endings. What we do here, we generally wash the wound with soap and water, and that water should be under running tap water for 15 minutes. And why is it important? It is important because it has been documented that the chance of developing rabies is reduced if we do this step by 80%. And it works maximally when applied immediately after exposure. If it is delayed, then this step do not provide much help. But again, whatever the case, we should not omit or skip this step. Local wound treatment and cleansing together forms the wound toileting. After the stage of wound toileting, we do a chemical treatment using firicidal agents. The most commonly used is the povidone iodine, 1%. Here, we must ensure that no suturing should be done to prevent the additional trauma. If you do suturing in the wound, then there would be micropunctures in the wound, and that lead to faster travel of the rabies virus through the nerve endings. Thus, suturing should be avoided for a minimum period of 48 to 72 hours. Thirdly, the antibiotics should be given to prevent the secondary bacterial infections. Anti-tetanus measures with tetanus toxoid should be administered. And rabies immunoglobulin is to be given as per the category of the bite. Now, coming to the categories of rabies bite along with the recommended post-exposure prophylaxis. There are three categories of bite. The first category is when When a person is touching or feeding an animal and that animal leaks on the intact skin, that is termed as category 1, and here no post-exposure prophylaxis is to be given. Number 2, when there is nibbling by the animal or minor scratches or abrasions, but there is no bleed, then it is termed as category 2, and here we have to give immediate vaccination with local treatment of the wound. If the animal can be observed for a period of 10 days, okay, then the further doses of vaccination can be omitted. Category 3 bite is when there is single or multiple transdermal bite over the skin. There are scratches on the broken skin, contact with the mucous membrane directly, or contact with bats or wild animals. Then it is category 3 bite, and in this case we have to give immediate vaccination with local treatment, and we have to add rabies immunoglobulin as per the body weight of the person. Coming to the regime that we used, first is the ascent regime. It is a 5-dose intramuscular regimen. Depending upon the type and the manufacturer of the rabies vaccine, it may be given uh, in 1 ml or 0.5 ml. It is to be given intramuscularly in the deltoid muscle in case of adults and in the anterolateral aspect of the thigh in case of children less than 2 years of age. There are 5 doses that are to be given on day 0. With day 0, I mean the with day 0, I mean that on the first day of administration of the rabies vaccine, that is considered as the day 0. Subsequently, on day 3, day 7, day 14, and day 28. These are the 5 doses of rabies vaccine that is to be given to the victim. Moving forward to the Zareb regimen, it is a 4-dose multi-site regimen. On the day 0, we give 2 doses of rabies vaccine intramuscularly. Subsequently, on day 7 and day 21, we give 1 dose of rabies vaccine each. Again, since it is intramuscular, it is to be given in the deltoid muscle in case of adults and in the anterolateral aspect of the thigh in case of children less than 2 years of age. Now coming to the post-exposure prophylaxis for previously vaccinated individuals. Here, for persons who have documented previous complete pre-exposure vaccine, only 2 doses are sufficient. It is to be given on day 0 and day 3. The pre-exposure prophylaxis of the same rabies vaccine is administered on day 0, 3, 7 and either on 21 or 28. This is the pre-exposure schedule that is to be given when a person who is at risk of contracting rabies. Generally, if you say these persons are the dog handlers, the veterinarians, the hunters, the naturalists who go to the field and wildlife, the wildlife photographers. With these professions, the pre-exposure prophylaxis is to be given. Again, the rabies vaccine, either in the pre-exposure prophylaxis or post-exposure prophylaxis, it is to be given either intramuscularly or intradermally, depending upon its type. Coming to the rabies immunoglobulin. The rabies immunoglobulin was given for category 3 bite. Okay, it is the passive immunization and it is to be administered only once. Do remember that beyond the 7th day after the first dose of vaccine, it is not recommended. So, it is to be given as soon as possible. And what is the dose? The dose is 40 international unit per kg for equine immunoglobulin and 20 international unit per kg for human immunoglobulin. The maximum dose for equine is 3000 international unit and for human is 1500 international unit. So, where it should be administered? It should be administered maximally in and around the site of the wound. Still, if some portion is left, then the remaining is to be given IM at the site which is distant to the wound. That was all for the today's lecture. If you have any doubt, you can always comment on the comment box. Thank you very much.